Raj Singh is Chief Medical Resident at Saint Vincent Hospital in Worcester. He'll be joining the University of Massachusetts in July to pursue a gastroenterology fellowship. He is an international medical graduate training at Manipal University in India. He joined the Saint Vincent Hospital in 2019 to complete his internal medicine residency and currently chairs the Council of Resident Fellow Members at the American College of Physicians, Massachusetts chapter. He spent his formative years in Doha, Qatar, and visits during vacations. Raj is an avid researcher and enjoys peer reviewing equally. Thank you for joining us, Raj. Talk to me about your education in India. Talk to me about coming to Worcester and your experience here, and differences in medicine there versus here, and what you've had to adjust to.
Absolutely. Thank you so much for your time and having me here, Dr. McGee, and every one of you. I trained over in southwest India, in a state called Karnataka, and the medical school I trained at is called Manipal University, and the program is Kasturba Medical College. In India, medical school training is 5.5 years. The 1 year of internship is integrated to the training process altogether. Healthcare is quite different in the way it is disseminated over in India as compared to the United States. The concept of healthcare in India is very universal. It is only a very small fraction of the population, of a very large population, that actually has private insurance. Everyone else, highly relies on the healthcare provided by the government. Now, the problem is that the proportion of patients is so large that it completely overwhelms the healthcare construct that is in India to provide a very holistic care to all of them. While over in the United States, there is a large emphasis on insurances, and a good 30 to 40% of the population is insured. When healthcare is seen over in the United States, I think it is seen with the intent of being preventative. I think healthcare in India is seen with the intent of being curative. For example, there is such a heavy emphasis on preventative medicine, on, for example, this is colon cancer, screening month. So the entire concept of prevention is better than cure is very heavily seen in the healthcare system in the US. While over in India, I think what we largely see is until someone really falls really sick, nobody wants to come into the care of a healthcare practitioner.
So your experience here as a resident and what you've experienced with the system, what sort of populations you've served?
Sure. So my experiences have been a roller coaster ride, and I think that largely has to do with the fact that when I joined as a trainee back in 2019, 8 months into my intern year, we were hit with the COVID pandemic, which was a very unprecedented situation, and that added a layer of complexity. So I'll answer your question with a few known variables first, and then we'll talk about the unknown that came on top. When we look at core medicine and the way it was practiced here, and when I look back and I observe, I think the construct of pain management is quite different in the United States as compared to where we train as international medical graduates. The availability and the expense and of opiates and its use as for analgesia, and just by the narcotic legislatures overseas, is just so much more tighter that we were not as exposed or trained to use opiates for pain management. it's very nice to understand and kind of observe that in the US when we care for patients, we not only want to cure them from the source of their problem, but we also want their journey to be one that is extremely comfortable and pain-free. And we uh, we emphasize on a very holistic care for patients. Um, when uh, when I look at a personal well-being standpoint, I think just by the nature of not being very well versed with the U.S. culture before coming in, we might be acclimatized to the regular flow of work within the construct of the hospital. There is still a lot more of acculturation that is left for international medical graduate, and that puts an IMG probably at a risk of seclusion, just because it is so tough to bond and gel in the work environment. And I think that is a potential source for causing emotional distress that stems from a very simple terminology of cultural shock, and that can spill over to where a resident, while in training, is just going through so much, might not be able to be competent, although he or she might be might have extreme potential to perform very well, but just because they're so shaken up initially. Another major issue that comes in as a barrier for IMGs to be able to flourish is the visa status and the visa situation. Now, most IMGs in the US are on a J1 visa. A J1 visa is an exchange visitor visa program. It is issued for a year, and once you enter through a US port of entry, you're given a duration of status entry stamp, which means that you can be as long as you are a trainee. And if you fall out of status or you're not a trainee any longer, you would have to exit the country. The issue is that every time you want to exit the country and come back again, and if your visa stamp has expired, you would have to go to a consulate and have that renewed. The visa also comes with a package that after your training is complete, you must exit the US and go back to your home country, unless you choose to find a waiver job and have that criteria waived off.
Mhm.
The complexity is actually now. So each waiver which is issued for a J1 visa applicant uh, is most commonly coming through the Conrad 30 J1 waiver program. The Conrad 30 is basically 30 spots, and most of the spots is for primary care physicians or hospital medicine, and a very few spots are actually delineated to super specialists. For example, if I take myself in the situation, as a gastroenterologist, 3 years down the line, I might have to pick a specialty that is not gastroenterology just to be able to find a job in the Conrad 30 J1 waiver spot. I might have to work as a primary care physician just because I couldn't find a spot in the gastroenterology, if that makes sense.
Yep. So
And
you've encountered a number of barriers. You've identified these sort of problems that you've encountered as an immigrant physician trainee. What strategies have you used? Because you clearly are successful in your undertaking here. So, having encountered these barriers, what strategies have paid off most for you?
uh, thank you so much for that question, Dr. McGee. And actually, in the context of being part of this interview, I asked the same question to myself while I was thinking in my head, the journey so far. And I think the strategy was something I did not particularly use, but it came to me, and that once again shines light on a very important situation. If you notice, if you take the entire span of medical graduates, American and international medical graduates throughout the United States, you will notice a pattern. And the pattern is that the IMGs tend to flock in certain locations.
Mhm.
You might see all or none phenomena. So a program X might have 80 to 90% of their house staff who are all international medical graduates.
Mm-hmm.
At the same time, you might have a program Y, maybe in some other part of the country, that has 80 to 90% of the physician as American medical graduates.
Mm-hmm.
Now, the reason for that is not only selection bias, but it is also selection bias from the applicant themselves. What I'm trying to say is, because international medical graduates probably acknowledge or understand that they are not going to have a huge social support when they come over to the US, they would want to flock to programs which are friendly, or in other words, have a larger cohort of people of their belongingness. And in this process, this selection bias just continues, and you'll have concentrations of areas where you'll have a lot of international medical graduates, and you'll go to South Dakota, or you'll go to some other part of the Midwest where you'll have no IMGs and only AMGs. And bringing me back to the question, I think I fell right into the selection bias situation. I am in a program which I find myself to be extremely well supported at. So I look back at my last 3 to 4 years as the best years of my life. But was it destiny? Did it all happen by chance? I think it was probably because I was meant to be here, because this program is friendly for international medical graduates.
Okay. Thank you very much for taking the time to speak with us today.
Thank you so much. Thank you for having me, Dr. Mali.